How can wearable simulation devices revolutionize nursing education and the development and mastery of crucial clinical skills? Let's talk all about the latest news in simulation innovation with Amy Cowperthwait, the founder and CEO of Avkin.com, right here on episode 311 of The Nurse Keith Show. Hey there, this is Nurse Keith. In these days of the COVID-19 pandemic, I'm still bringing you my monthly pandemic updates at the end of each month. Meanwhile, this podcast continues to be all about you, your personal and professional development, your nursing and healthcare career, and the healthcare system as a whole. And I'm here to share education, ideas, diatribes, and informative interviews with some of the most inspiring people from the worlds of healthcare, nursing, entrepreneurship, technology, medicine, and beyond. I love having you along for the ride. Whether you're new to the show or you've been on this journey with me for months or maybe even years, over 300 episodes, thanks for being part of the growing Nurse Keith Nation. And did you know that Nurse Keith Coaching is your destination for all things related to your career? I offer individualized coaching for nurses and other healthcare professionals all around the world. And if you mention the show, you can get 10% off your first coaching package. So email me at keith@nursekeith.com for us just to hop on the phone and have a chat. The show notes for this episode, where you can learn all about Avkin and all about Amy Cowperthwait, will be at nursekeith.com/the word episode and the number 311. Amy, welcome to the show, and we'll get to your bio in due course throughout our conversation. We'll touch on your illustrious history and all the cool things you've done. And I just want to ask you an initial question just to jump off the cliff here together, or into the fire, whatever metaphor you want. So what is the state of simulation technology on average out there in the nursing education world? What's happening with simulation?
Well, thanks so much for inviting me on, Keith. I'm really excited to be able to share. I think the biggest thing regarding the state of simulation technology is it's a bit varied because it's a fairly new industry. Really got its legs up underneath of it in the early 2000s. And at this point in time, in most all nursing education, as far as pre-licensure, there is a sophisticated simulation center somewhere within the boundaries of the university, which will typically include at least one, probably more than one, high fidelity mannequin that has a pulse and a heartbeat, with multiple mid fidelities, and they have varying levels of ability. So in other words, in this, you might, for a high fidelity, you would see the chest rising and falling. You could put an ET tube down and intubate, for anesthesiology or nurse anesthetist, and then you could also, do some more sophisticated cardiac rhythms. For the mid fidelity, it's really, you could feel a pulse, but the chest doesn't rise and fall. You really, are limited as far as your advanced skills. And then there's also some very low fidelity mannequins there as well. They're working on AR and VR. That is pretty, that's very new to the world in general, but especially to healthcare simulation. And then also there is a movement within the simulation world towards simulated participants or simulated patients, which is really where I have my most area of expertise. And that's live people that are trained to be patients and family members. And there's technology that now can be made or used for advancing the invasive procedures that could be done on these healthy people that are pretending to be sick.
Wow. Okay. So let me unpack this for a second. So
Sure.
Low fidelity, mid fidelity, high fidelity. That's kind of new to me around simulation, though I read through your website and the information you sent me. So I did notice you talked about high fidelity mannequins in terms of your company. So I got that. Now, AR and VR are augmented reality and virtual reality, right?
Mm-hmm.
So that's a thing, right? That's kind of coming these days.
Yeah, the technology is pretty new. It's limited. So if you think of surgical procedures and things along those lines, where it's really high stakes that they get something correct. They're becoming more mature. There's also some, if you think of nurse practitioners or physician's assistant schools where they have to go in and do a test where they interview a patient and do a health assessment. There's some virtual patients that, are kind of in that realm. But there's not very much sophistication out there. There's still a lot to be learned. And I think one of the biggest challenges with that is that you have to be able to use your hands. They have to know where your hands are in space and time to be able to, really calibrate, I guess would be the right thing. But we need to be able to have them put on sterile gloves or hold instruments in their hands as they're doing procedures. So that's still a challenge to really overcome as far as healthcare is concerned.
Right. And then when you mentioned in that amazing description, introduction to this world, you mentioned live, trained professional patients, more or less. And a lot of us have, or I have, done CEUs where there's trained actors for mental health simulated patients where they act out, schizoid personality disorder, whatever, So that's one thing. But to be a trained patient to actually, undergo a simulated procedure is another thing. And we're going to talk about Avkin's technologies and how it doesn't mean that a person who signs up as a simulated patient isn't going to have, they're not going to be catheterized 15 times a day. We're going to talk about how we get around the discomfort and safety issues and infection issues around actually doing a catheterization on an actor, for instance. Though that should be a very highly paid profession if someone's doing that. So a lot of things are changing. And first, I just want to say that, you're master's educated. You're also a clinical nurse specialist. You're the CEO of your company, which we're going to talk about in the second half. And then you have these other initials at the end of your list of credentials after your name. And it's one I'd never heard of before. And you told me what it is, but I'm going to ask you here so you tell the audience. So it's CHSE. What is CHSE and where does that certification come from?
So it is a certified healthcare simulation educator, and it is a certification that comes out of the Society for Simulation in Healthcare, which is one of the three largest simulation nonprofits in the world. And that the point behind that is that there are credentials, there is a review of your resume and what you have done as far as simulation, and then also an exam to complete. Okay,
so it's the Society of Healthcare Simulation?
No, Society for Simulation in Healthcare.
Almost, I got it. Okay, and then it's a certified healthcare simulation educator.
Correct.
Okay, so for those out there who are interested in technology and interested in the innovations in simulation, which I'm assuming 10 or 20 years from now, we're going to be looking at really sophisticated augmented reality and virtual reality. And so if people want to get involved in these sorts of technologies, it sounds like this is sort of the time to hop on board, right?
Absolutely. If you have at all an interest or a desire to watch and see people learn, watch the wheels turning as they're really growing in their knowledge, whether it's pre-licensure or post-licensure, and then also a willingness to adapt to some technology. It is definitely a very interesting field. And, as I said, we're kind of late to the game. The military has been doing simulation for years and years and years, as well as aviation. But healthcare is really fairly new. We started in the early 2000s and have really started to take off. But it's still a growing field, and there's lots of opportunity.
Yeah. So speaking of the military, I mean, a lot of medical advances do come out of the military. World War I, there were advances. I mean, there were advances during the Crimean War with Florence Nightingale, right? And there were advances in Korea, World War II. There have been advances during the wars in the second half of the last third of the 20th century. So the military can drive a lot of this, but it sounds like there's a lot of stuff happening in the private sector.
Yes, because I believe that healthcare delivery is very different in the military versus the healthcare sector. Just thinking about it, insurance and how that factors into everything, payables and, all of that. So I think that even the key metrics for the way that healthcare is now being held accountable for their hospital-acquired infections and all of those things, I think that their pain points or their deliverables are different. And so, because innovation is really a disruption of an industry because you're trying to solve a problem, I think they just have different problems. And that's why there has been a lot of innovation within the private sector. Doesn't mean that the military hasn't done some wonderful things as far as simulation goes, because they have, but theirs is really focused on, battlefield recovery or immediately post-traumatic event, and less on the longer term, although that's changing a little bit, but it's just a different focus and a different problem base.
Right. And we have innovation happening through the members of the National Nurses in Business Association, where I've been associated for a long time. And, there's a lot of product developers and innovators, people who've been developing prototypes for all sorts of things. Then we have SONCIEL, the Society of Nurse Scientists, Innovators, Entrepreneurs, and Leaders. And then we have Tim Raderstorff and his group over at Ohio State University. I know you know him, and he's been on my show. And then we've got Marion Leary, who hosts the Amplify Nursing podcast from UPenn, from Penn Nursing, and they also are deep into innovation. So, we're hearing about it all the time. And then we hear about companies like your company, Avkin. So before we get into Avkin in the second half, I want to talk about what's on everybody's mind for the most part. So, we don't want it to be the elephant on the table, of course, because we're not letting it be. There's the pandemic, right? We're recording this on January 13th, 2021, and we're almost a year in. We're getting really close to a year. And I just heard in the news today that in England, they've lost more citizens than they lost in all of World War II as of today or this week. In the United States, we're losing more people than those who died during the 9/11 terrorist attacks in 2001. We're losing that many people every day. So things are not pretty. And during the course of this, a lot of us, and I bet you have been too, and Marion Leary and a lot of educators, we're worried about how do we train our nurses, our nursing students, to be skilled clinicians so that when they get out of school, obviously they're not going to be experts, they're novices, but they're at least going to have, as much training as we can possibly provide. And I know some schools are getting their students or have gotten their students back into the clinical space. I have a friend whose daughter is up in Flagstaff at University of Arizona, and she's back in the clinical space and has been since last semester. But this is an issue for not getting enough hands-on, right? And I've had conversations about what are we going to do with these students when they graduate? They pass the NCLEX, but it's no fault of their own that they haven't had enough hands-on. And this is where the AR comes in, the VR comes in, but that's still in its infancy, really, or toddlerhood. And that's where we have things like what you're doing. So from your perspective throughout the course of the pandemic, and you founded your organization, your company in 2015, so you really predated, you were way ahead of the curve. But what is going on, and how have you seen nursing education in terms of physical hands-on skills taken a bit of a hit?
I would agree with you. I'm still an educator at the University of Delaware. So I have two passions, but they both speak to each other as far as skill sets, knowledge base, and talents and abilities. So what we saw initially in March and February and March, as everything was unraveling, was we weren't prepared. We weren't prepared that we never thought in a million years that our students would be asked to not come back to clinical, or that the university would completely shut down its entire operations and everybody would be sent home. That just was completely shocking news. And I think I've been asked before, what would you say then to, educators and nurse leaders in the pre-licensure state is, we now know it's possible and we can't get caught this way again. Simulation is a fantastic medium to provide an alternative for hands-on. Now, initially they weren't, because the universities were shut down completely and they hadn't considered that there was accrediting bodies and, requirements for clinical by the boards of nursing, we had to do everything virtually. So even at Avkin, we converted a lot of our simulation learning opportunities or offerings to a virtual platform, because if they had been taught the skill, then you could have a patient at home with, let's say, a tracheostomy wearing the device and a family member calling and saying, I'm not sure how to suction this patient, my husband or my wife or whatever, can you please help? So, again, if you can teach it, then you know it. But if they had never been taught the skill, you can't expect that they're going to be able to explain that or teach it. So some of it was that we had to focus on the communication skills. We know that about 80% of all Sentinel events are secondary to some type of communication lapse. So we can work on that virtually. And that's really, where we stuck with is the cognitive and the affective domains, and thought, well, we'll bring them back and get skills in the fall. And as we all know, there's some truth to that, although a lot of regulations with how many people can be in one particular room. But the universities got smart and didn't just shut down all of the university. They did open it up, again, by and large, to engineering students who have to be working together, with tools and things, and then nursing students and places that had, required clinical hours. So with a reduced amount of students per hour, and a lot of regulations, they were able to bring them in and work on some skills. But regardless, they're not going to come out. These students that are graduating now and probably in a year or two are really going to suffer. Now, even if they know the skills, it's the confidence that they can do these things. And that's where simulation really shines, that we can give them these unusual circumstances or patient presentations that they would normally see in a clinical environment, but has all the competencies that they're going to need in order to do the patient care. I still believe firmly that there's a combination of simulation and clinical learning. I think that they go hand in hand, but we do need to have a more sophisticated simulation program, and the awareness that they could take away our clinical sites again. One thing we also worked on is the idea that, okay, if these students are going to graduate and not be as prepared as they were before, let's build a curriculum that's focused on the top 10 most common nursing errors. Mm-hmm. And that really drove what we did at Avkin through COVID. Was we created curriculum that focused on, managing lines and tubes, failure to rescue, mm-hmm. professionalism in the clinical environment, all the things that the Joint Commission and Quality and Safety Education for Nurses points to as far as the most common errors, so that as these students graduate, if they aren't prepared, we can put them through an orientation, a 10 simulation experience to really get them comfortable. And because our products allow for the idea of psychomotor skills being incorporated with live people, it's much closer to what they're actually going to experience in the clinical environment, but not putting any actual patients at risk or themselves at risk.
Well said. Oh my gosh. And I've had some conversations on this show and offline with people about how, this is another conversation. I just want to mention it. How nurse residencies at hospitals and medical centers are these elite, very difficult, highly competitive environments, and only a fraction of nursing new grads get into nurse residency programs. They're highly competitive. Personally, I feel like nurse residency programs should be ubiquitous at every medical center in the entire country, and that they need to be subsidized somehow. But that's another conversation. Medical students get their residency and their internship and all these other types of things. And nursing students, new grads, need this leg up too, because it's about patient safety and actually quality of care. So, that could go a long way. But again, it's another conversation. So we've touched on the pandemic. We've touched on how we have low fidelity, medium fidelity, high fidelity. We've mentioned augmented reality, and we've mentioned, all these different, what would you call them? Technologies that are being developed. And there's all these different ideas for how to take these innovations and bring them up several notches. And you're an educator at University of Delaware. You're also the CEO of your company. You're also a clinical nurse specialist. You're also certified as a healthcare simulation educator. And you're not solely coming from the point of view of being an educator and a simulation specialist. You were an ER nurse for many years. You found your niche, transitioning into, simulation environments and that sort of thing at University of Delaware. And it sounds like, from what I read in your bio, that you saw a trach simulation gone awry, whatever that means. And I want to ask you what that means. And then you decided, how can we add a human element to these standards around how we do simulations? So before we take a break, could you just describe what this trach simulation gone awry was? And then we're going to take a quick break and come back and dive deeper.
Sure. I want to preface it by saying that when I was a nursing student, I had a trach patient as one of my completes, that you always get a complete patient
Sure.
before you graduate. And I had a really noxious experience with suctioning that patient because the patient was semi-comatose, but when I hit the carina, again, unknowingly, the patient reacted, and it scared me because I didn't know what to expect. And I thought, this patient's coming alive and is,
Oh, no.
It just really was very terrifying because, as a student nurse, you're just trying to figure everything out, where your hands go and make sure everything's sterile. But I mistakenly hit the carina, and the patient, reacted with that nonverbal reaction. And so I've always had this kind of special place in my heart to prepare nursing students or even novice nurses on what to do when they have a patient with a tracheostomy. But the tracheostomy sim that you're referring to was that we had a mannequin, and at that time, that's all that we had available to teach tracheostomy. And the students were to go in and they were to see a patient in respiratory distress. So when they walked in, the patient was breathing rapidly at about 30 times a minute. And if they listened to the lung sounds, they would hear crackles and recognize that they needed to suction because, again, I'm working with novices and they were junior level. So they were pretty green. But what happened was they walked in and they said, "Mr. Jones, what's your birthday?" And I, as the instructor, if my patient was verbal, could speak through a microphone and it would come out of the head of the mannequin. But I didn't react or I didn't respond because I wanted them to recognize that trach patients can be nonverbal and that they would have to work through another way of communicating with the patient. But when Mr. Jones didn't answer them, they went to feel for a pulse. And when they went to feel for the pulse, they squeezed the wrist too tightly and they didn't feel a pulse. And all of a sudden, we're doing CPR on Mr. Jones because they think that he's passed away. And he's not actually dead. He just needed to be suctioned. And I just kept thinking, if I could just have a nonverbal patient, if I could just have a real person in the room that has some type of an appliance, that they could look at the patient and the patient could look back at them or, try to mouth something to them like patients do, or write something on a pad, they would understand. And the objectives for that simulation would have been met. But they didn't understand what was happening. And I just kept thinking there has to be a better way because we know that about 80% of our communication is nonverbal.
Yes.
So we still need to incorporate that piece of it. And that was really, really, poignant to me and kind of a mark in the sand as to when I said, okay, I'm not going to just accept what's out there. I'm going to make a change and do something different.
Wow. Great story.
Thank you.
Really good story. And that's a really perfect illustration to lead us into the second half and talk about how you brainstormed and actually came up with the idea to create a certain type of technology that could actually help a real live patient, so to speak, quote unquote, actually be there and respond without having to have an actual invasive procedure done on them by a student nurse. So when we come back from the break, we're going to dive deeper and talk about what the Avkin technologies are really about and how they came about and what your plans are for the future. So we'll be right back for the second half of episode 311 of The Nurse Keith Show. So now we're going to take a pause for the cause for just a moment. Please consider becoming a patron of The Nurse Keith Show, just like other awesome listeners who value the show so much that they want to give just a little bit each month to support the work we're doing here. When you pledge, you not only get the satisfaction of helping produce and support The Nurse Keith Show, you also get some pretty cool premiums and gifts from yours truly. Just head over to patreon.com/Nurse Keith to read all about it. That's patreon.com/Nurse Keith. And if you know someone who could benefit from career coaching with me, please consider referring them. And if they become a paying client, you'll receive credit for an hour of coaching with me. And there's no expiration date on that credit, so you can keep it in your back pocket until you need it most. And remember that you can refer as many people as you like and continue to earn those coaching credits. What an incredible deal. And please head over to nursekeith.com and sign up for my newsletter, which comes out regularly and brings you supportive messages, updates from my blog and my podcast, resources, and all sorts of other stuff. Remember, nursekeith.com, sign up for that newsletter, and you'll also get a free download from me as my gift to you. Anyway, those are my sincere asks today. So now, let's dig back into today's topic without further ado. And welcome back to the second half of the Nurse Keith Show, episode 311. And remember, you're going to want to go to nursekeith.com/the word episode and the number 311 to learn all about Amy Cowperthwait, read about her bio and her history, and read all about Avkin, her company that she founded. And we're going to dive deeper into that right now. Okay, Amy?
Sure.
Okay, so right before the break, we were talking about a trach simulation gone awry. And nobody died. It was a mannequin. But you illustrated for us that the nursing students made some observations and poor choices that led to them doing CPR on a quote unquote live patient who was not dead, whose heart hadn't stopped. And because of the limitations of that not quite high fidelity mannequin, there was only so much you could do to communicate with them. You had the microphone, you could talk through the head of the mannequin and things like that, but the mannequin couldn't actually respond, right?
Correct. And again, in the trach patient simulation, I didn't want him to talk. I wanted them to I wanted them to understand that trach patients cannot be verbal,
right?
And that they'll have to come up with an alternative.
Right.
Yeah.
And if you have a mannequin without arms and, unless you had a mannequin where you could actually move the arms, from afar, there's only so much you can do as an educator. And then you have to unpack the experience for the students who might be traumatized by that point and say, okay, so what went wrong here? So going back to the simulation, which sounds like it was before 2015 because you founded your company in 2015, right?
Correct. Mm-hmm.
So when did this trach simulation gone awry occur?
2012 is when it went awry, and 2013 is when we got started.
Okay, so we'll put that 2012 trach simulation in the history books. Simulation gone awry. Sparks CEO of new nurse-led company. Film at 11. Okay, so, all right. So you started thinking, what can I do here? So you're a nurse. You're a nursing educator. You are a clinical nurse specialist. Your master's prepared. So obviously, to me, you went to the nursing process. So you started assessing what the heck is going on and how can I change it, right? So tell us your thought process around once this trach simulation went awry, where did your mind go?
Well, I think it really started in 2006 when I was hired there. I was still working part-time in the ER, but I came out of the emergency department and I knew what clinical care was and what the expectations for clinical care was. And part of my responsibility was to get these students ready for clinical care. And I just felt as though the mannequins had significant limitations. And I did try. I tried to talk to the mannequin companies, to our salespeople and say, hey, could you do this? Could you do that? But remember, they've spent thousands. I mean, at the time it didn't dawn on me, but I know now they've spent thousands and thousands and thousands of dollars on the research and development of these innovations of these high fidelity mannequins. So to make the tweaks and changes they needed to be able to, make simulation better or make clinical care more realistic, they just couldn't do it. They couldn't manage those changes, especially, think about discipline specific things that you would need. They just, it was a broad, one size fits all. And so I really became frustrated with that. And I think most nurses typically, when we assess a situation and know that it could be better and it has to be better, we start looking around for ways that we can make things better. So I had a relationship with the theater department. By this point, I'd already developed a relationship with the theater department, and we were co-teaching this course to provide simulated patients for our simulation. So we had about 20 students every semester, and they were family members for the mannequin simulations, or they were patients for the ones that didn't need invasive procedures. And I successfully gotten this program with the collaboration of the theater department and the physical therapy department up off the ground. So when I was looking for a way to solve my problem of, I want to have a live person in the bed wearing something that simulates a tracheostomy, but also signals that they need to react and respond in real time, I began looking around for faculty members in the engineering department. And I found Jenny Buckley, who worked in the Department of Engineering, and they have a course. It now became theater students, nursing students, and engineering students working together on this project. But it's called Senior Design, and they identify what the problem is, and they have to come up with a prototype in 15 weeks. And so, we sketched out, the idea of what we were looking for and what we needed, and kind of the deliverables, the must-haves. And one of the must-haves was that when they hit the carina, because of my experience as a student nurse, when they hit the carina, the patient would get some type of notification so they could react in real time. So the students would go into their clinical settings prepared for what could happen. There was also needed to be a sensor at the faceplate. So then again, the patient could react the way the patient does if they're pushing too hard on the faceplate. So it created this awareness in real time. But then they also got to get feedback from the patient at the end of it. So the idea was, we called it a tracheostomy overlay at the time. We call it AvTrach now, but let's create this. And they said to me, well, electronics and mucus don't really work well together, because I wanted them to have to actually suction out simulated mucus, which is another limitation of the mannequins. And I said, well, you have 15 weeks to figure that out and get it done. Go for it. And it was basically a double course. It was six of their college credits, and they care a lot about their GPA. So they were able to really get this idea from my head to my hands. I call it my Walt Disney moment, where something that I had dreamed of and imagined now became a product. And I always joke, because I thought I was going to get, so when our customers order the AvTrach now, that's what I thought was going to be delivered to me. But it was really a prototype that looked like it was put together with bubble gum and glue. It was casting material and yoga mats to reduce costs, but it was what I had asked for. It was so cool to run our first studies on that and see the nurses' reactions and see the reactions to the patient's reactions, which we could never do before. It was really fun.
That's amazing. And that's multidisciplinary collaboration at its best. Engineering students, theater students, and nursing students. Who'd have thunk it? And speaking of collaboration, George the cat just kind of hopped up on the desk. He wants to get in on the action here. He's a wannabe podcaster or pawcaster, as we call him. So he's hanging out here with you. So, okay. Where do we begin? There's so much to talk about. So, all right. So we have multidisciplinary collaboration. You came up with this idea, like you said, from your head to your hands. You wanted them to deliver something to you, and it was high stakes because they wanted an A. So they had to create this, even if it was bubble gum and, Band-Aids or whatever. So you had this notion that we could actually have a live trained actor, and you can put a trach device on their around their throat, basically, and there are sensors in there. So if the student hits the quote unquote carina, the patient's going to react, and the patient will feel something to tell them it's time to react, right? So is it like one of those, way back, I might be dating myself, or I think I am. I'm sure you're much younger than me, but when you used to shake hands with someone and you'd have a buzzer in your hand and it would buzz, is it something like that? Like they get a physical signal that they've hit the carina?
Yeah, not quite as noxious.
Oh, good. Okay. My son used to use those a lot when he was a kid. So
the device is actually a whole chest piece because they also need to have abnormal lung sounds.
Oh, it's
right?
a chest piece too.
Yes. It really goes from, about chin to their lower abdomen.
Oh, I didn't get that. Okay.
Yeah. So
okay.
it because it has lung sounds. So think about the idea that you want the students to use their own stethoscope, and you want them to be able to hear lung sounds. So that was another must-have from my perspective. But it's really it's the exact same thing that they use to vibrate a cell phone is what is in the strap of the product. So if you kind of reverse backpack,
yeah,
the chest piece is on the front, and then the straps are in the back, and then the vibration goes off in the back to signal a response from the patient, the trained person that's wearing the device.
And then the trained patient knows which signals mean what, right?
Yeah.
So they learn, right?
It's different straps, but typically, we just teach them that if they're suctioning, it's really going to be the carina sensor. And if they're doing tracheostomy care, it's going to be the faceplate sensor where they're pushing hard. Just because it's slightly different reactions, the patient has slightly different reactions to those. So we wanted them to see the real reaction that the patient would actually give.
So once you had this prototype, then I'm sure you went through the iterations of, you create another prototype, and then you have to figure out finding a manufacturer who's actually going to make them for you. And then you have to make sure those are correct, right? And then you have to see how they can actually get produced in larger numbers. So this is a process. I've heard about this at the National Nurses and Business Association, and people at Sun CL know all about, how you develop an actual product. Tim Raderstorff knows about it. Marion Leary knows all about it at Penn. So, it's not a simple undertaking. And you created a company, right? And you're the founder and CEO. So it's avkin.com, AVKIN. So can you explain where Avkin came from? And then had you started a company before and been a CEO before?
I always say I'm the world's least likely CEO that happens to be a CEO.
Okay.
I had no desire to start my own company. We are, the technology is housed, the patents for the technology are housed at the University of Delaware. And we reached out to the mannequin companies and some of the other simulation companies to try to get someone to take the concept and license, make them and sell them. Mm-hmm. But we really couldn't get them interested. And so I believe so firmly in this, and I knew that this was the next wave in simulation, that I started the company on my own. And I shouldn't say on my own, because it wasn't me by myself. It was a team of people.
Sure, of course.
So the things that you described about how to get things started, I had no idea what I was saying yes to when I said yes. But my passion, I just firmly believed that this was such a better way to make sure that students and even post-licensure nurses that aren't comfortable with certain patient interactions or procedures, that they needed the opportunity in a safe place to practice them. Mm-hmm. So I endeavored to learn all of it. I'm an ER nurse, so we take it one step at a time. Mm-hmm. And I had some great mentors and a fantastic team around me.
Amazing. Wow. And you had the university behind you too. So that must have been super helpful.
It was. Yeah. It definitely was.
Yeah. That gave you some mentors and people to lean on, not that, you probably needed to get snippets of information from all different people, because not everybody knows how to create a prototype or whatever, founding a company, there's a lot involved in founding a company, let alone developing an actual product that you can actually produce, manufacture, and sell, and then continue to have quality improvements and all that sort of stuff. So as we, wind down, so we have sensors, we have trained actors, you've got, that interdisciplinary credit course where all those different students from different disciplines got together and were like, okay, we're going to get an A, we're going to create this. And now here you have this company, right? So you obviously want to earn money at it too, because this is not a cheap endeavor either. Like you're not just creating a mannequin where people do CPR. Those are cool, but they only go so far. This is like high level technology. These are high fidelity mannequins. So you have the trach and the chest plate, right? What other devices have you put to market and are actually being used now out there in the world?
So our second product was the AvCath, so urinary catheterization. And in that one, it's really focused on the realism of the genitalia, the realism of when you're going to see a urine flow,
wow,
the lack of leaking, which is a big problem.
Okay.
And then the sensors are located at the entrance to the bladder. So if you think of a urinary retention simulation, the patient would need to know when they would feel better, right? So that one is kind of the opposite of the trach simulation. And then also for females at the entrance to the urethra, because they usually have a quick jump in that for that one. So that's our AvCath. And again, that is really focused on creating that realism for what they would actually be experiencing. Mm-hmm. And then we have the AvStick, which is our IV sleeve.
Okay.
So that again gives great blood back, and they can do phlebotomy and, hang fluids and all the things that they would need to do. There's a central line device, and that one isn't actually the insertion of central line yet, but it's the actual care of central line
device. Yeah. Cool.
And that one has a sensor at the where the central line is inserted, so that if they push too hard, that the patient can react the way the patients do.
I see.
It has a triple lumen as well as a portacath in that one.
Great. Great.
The portacath can pop forward if they want to use that, and then retract back if they don't. So it's not confusing.
Yeah, I see. Okay. So
one more.
One more.
Actually, two more.
Oh.
One is a heart and lung sound simulator. So it has anterior and posterior chest. So if you want, a cardiac patient that has a history of congestive heart failure with, S1, S2, S3, S4, you can do that, or any abnormal lung sounds. And then the AvThor is our chest tube simulator. So thinking about negative pressure, high levels of fluids being into the closed chest drainage system.
Oh, yes.
So, and we have a few more coming out this year as well.
Oh my gosh. Wow. That's a lot.
Those are the actual physical products, but then we also help people with their SP programs through educational services as well.
SP?
Sorry, simulated patient or simulated
patient. Okay. Okay. So that's a lot of products that you've developed and they're out on the market. Wow.
Yes.
And I'm assuming when you train the actors, the urinary catheterization one is a little more sensitive because, the students have to be working in that vicinity of their bodies. So they have to be trained and comfortable. And, the students still have to approach them sensitively and tenderly because, even though the actor is quote unquote, just wearing a simulating device, they're still approaching them in that very sensitive area of the body. So it gives the students sort of not just a simulation of the actual, procedure, but a real live, like approaching a patient saying, I'm going to touch you down here now. So that's kind of a double layer for all of these in a way, right? There's Absolutely. The behavioral part, I guess you would say, right?
Yeah. So, and also the fact, it's what they do, it's how they do it. So if you think about putting in a catheter, if their hand is shaking so hard that it's very clear that they're nervous, that all can be worked through in simulation versus working it through on a real patient.
I see.
And also the idea of getting feedback at the end of the experience. So at the end, the character breaks from who they are in the simulation and can give feedback from the patient's perspective about how they felt and what went well, what things to keep and what things could be improved upon to help these students. And they love it. They love that feedback.
I'm sure. And, I can just imagine of course you can have trained actors from the theater department come in and do this. However, if you get physical therapy students, pre-med students, and students from other health services coming through as trained actors, they can give even more really salient feedback because they're being trained as physical therapists or physicians, right?
Well, the interesting thing that you say that is, I remember I mentioned that we started teaching a course where we trained the students in the course to be our patients.
Yes.
Almost 90%, maybe even a little more, are pre-med students or pre-physical therapy students. And what they say that they get out of that experience of wearing the devices, of being the simulated participants or being the simulated family members, is they see healthcare from a whole different lens. So, imagine that you're now the one laying in the bed and receiving the care. So we get comments with the tracheostomy device. I had no idea how long that suction catheter looked until I was the patient. I had no idea how, it looks to have a nervous clinician coming into the room or a non-confident clinician. And because they actually see, typically they are the patient for 10 or more of these simulations, they get to see multiple groups coming in and providing care. And they get to see, these are the good things I'm going to take from these experiences and put into my actual practice. And these are the things that I'm never going to do. It's really a win-win. And the ones that are wearing it are learning as much, if not more, than the ones that are actually practicing it from the patient's perspective.
That's fantastic. And then if you, not to cast aspersions on young med students and young nursing students, but if you're a young, healthy 20-something, you've never been in the hospital. You've never been catheterized. Maybe you've never had a health problem of any kind in your entire life, or maybe you have multiple sclerosis or something, and you've actually been in the healthcare system as a patient since you were a child, right? So you have med students and nursing students who have a plethora of life experiences they bring to the table, so to speak, as well, right? So some might just not even know what anything feels like because they've never had to feel it. Maybe they've watched their grandfather get suctioned or something. So this is so fascinating, and I'm sorry we have to wind down here, but I just feel like, from the point of view of where you're coming from, there's sort of like no holds barred around where this could go, and what you're doing now could actually be combined with virtual reality and augmented reality and become even deeper. And I'm sure we could have another conversation about that. So I just wanted to ask really quick. So Avkin, Avkin, I get the KIN, right? Which is mannequin, right? But AV, am I missing something?
So we had to rebrand about a year and a half into our company history, and that's a whole nother story.
Okay.
But when we did so, we actually had a little bit of money that we could pay a marketing company to help us.
Yeah.
So what they first do is look at what .com is available, and akin.com was available. So if you think of akin, just like the idea of mannequin,
yeah.
And we thought, oh, that's great. But then we found out that we couldn't trademark it, which was one of the problems from why we had to rebrand. So then we began to look for Latin words because, there's so many different things. So they suggested the word ver. So VER means true.
True. Right.
So we thought, truly like the real thing.
Mm-hmm.
So it would have been Verikin, right? Mm-hmm. That would have been the name of it. But they wanted us to have A as the first letter.
Mm-hmm.
So we then went to Avkin, right? So it moved the A to the front. But then we thought that sounds too much like American, and they could misspell it with the .com. So we just shortened it to Avkin. So that's, in our hearts, it means truly like the real thing.
I like the ver from the Latin, like verdad, or in Spanish. So I like that. That's nice. And it's always cool to hear where these names come from. Some of them are just pulled out of the air through marketers, like the way they think about letters and how they work psychologically and stuff. So good. I just wanted to understand that. So if people want to learn about Avkin, it's avkin.com, right? And do you have a social media presence as well?
We do. We have Twitter, Facebook, and LinkedIn. Mm-hmm.
Twitter, Facebook, and LinkedIn. I want to say, just as a person who just likes marketing and all that and social media, that I think Instagram would be a really good platform for you all because it's so visual. So
we actually might have an Instagram. I apologize. I am not an Instagrammer. So okay. I know that there's been some conversation about it. So
if I find it, I will put it in the show notes. And the show notes will be at nursekeith.com/the word episode and the number 311. So Wow, Amy, you're awesome. This is amazing. And it'll be great to have you back, like say in 2022, when you have more products out and maybe there's some new innovations that we can talk about. But this is fantastic. And I think in the context of the pandemic, this, I mean, your timing is just couldn't be better. So thanks for helping improve nursing education, because it's actually going to benefit me when I'm in the hospital. So, I'm 56 going on 57, and, I'm going to end up there at some point, I'm sure. So,
We're gonna be there.
yeah. So thanks for helping make my healthcare better.
I understand. I'm sure.
Yeah. So thank you. You're really wonderful.
Yeah, no problem. Thanks for having me.
All right, there you have it. Thanks for listening to this episode. And remember, the show notes are at nursekeith.com/episode and the number 311, where you can learn all about Amy Cowperthwait, Avkin.com, see links and all sorts of stuff so you can learn all about them and share it with people you know who would benefit. I hope you feel uplifted, empowered from this episode, and I encourage you to take inspired and innovative action like Amy has throughout her career in the interest of your personal and professional satisfaction and your career growth. And remember, if you need personalized holistic career coaching, whether you're a nurse, physician, physical therapist, social worker, remember you can come to me, mention the show, and get 10% off your first coaching package. And remember, at nursekeith.com, there are job listings from Reload, Trusted Health, Incredible Health, ZipRecruiter, excellent resume templates from the Resume RX, and a lot more. The Nurse Keith Show is a member of Ars Longa Media, speaking of Latin, a collaborative network of podcasts and media entities dedicated to professional education and partnering to improve social ills. They are at arslonga.media. We are also a proud member of the Health Podcast Network, one of the largest and fastest growing collections of authoritative, high quality podcasts taking on the tough topics in health and care with empathy, expertise, and a commitment to excellence. Check them out at healthpodcastnetwork.com, where you can see Amplify Nursing with Marian Leary of UPenn, Sanjay Gupta of CNN and his Coronavirus Fact versus Fiction podcast, and a whole lot more. The Nurse Keith Show is adroitly produced by Rob Johnston of 520R Podcasting, and Mark Cappy Speeson is our stalwart social media ringmaster. My thanks to Rob and Mark for keeping the wheels turning in the right direction. Otherwise, I might make them turn backwards. Be well, dig deep, seek joy, keep in touch. This is Nurse Keith saying adios till next time from beautiful, windy, and cold Santa Fe, New Mexico, and our new friend of the pod, Amy Cowperthwait, bidding you adieu from
Delaware,
the state of Delaware. Thank you, Amy.
Thank you.
Thanks for everyone for being here with us, and we will catch you on the flip side.